So good afternoon, everyone. Today we have got some questions on neurology that we'd like to discuss. So I'll be putting the questions on the screen. Go through the options and please point out what you think is the correct answer. So this is a question regarding gabapentin. Which of the following statements do you feel is correct? As you may know that gabapentin is one of the anticonvulsants which are quite commonly used. They have also got other use apart from being anticonvulsants. So they are used in neuropathic pains as well. So phenytoin and phenobarbital are another class of anticonvulsants which are commonly used, and they are the ones which are enzyme inducers, the hepatic enzyme inducers, but gabapentin is not. So the answer in this case is that it does not require any dose adjustment in renal diseases. That is why it is quite renal friendly, and you can use it in even end stage kidney disease patients who are on dialysis without reducing the dose. Unlike other anticonvulsants, if you are using it such as phenytoin or pregabalin or other things like that. Okay. So the next question is: a 69-year-old lady presents to the pain clinic with a 1-year history of gradually increasing pain in her legs, and there is associated weakness as well in both her legs. There is no past medical history. She does not smoke and she does not drink alcohol. Her knee reflexes are reduced. She has a fasting glucose concentration of 116. What is the next best investigation to confirm the plausible diagnosis? Please mind that the question is asking the best possible investigation that you would do in this case. So, what you see in this patient is you basically get a case of bilateral lower limb pain associated with weakness, and the question gives you a clue that the fasting blood glucose levels are slightly high. The range cutoff that they have given is 100 and the patient gives a value of 116. So this is one of the complications of diabetes which the patient may have had developed but she did not realize it, and this is what is called as a diabetic amyotrophy. This is more common in elderly diabetics rather than in the young patient population with diabetes. And so, to confirm the diagnosis, you need to subject the patient to a formal oral glucose tolerance test where you give the patient 180 grams of glucose and then again check the value, the blood sugar levels after 2 hours to make a formal diagnosis of diabetes mellitus. So, this is a 58-year-old gentleman who attends the outpatient department with an 8-week history of lethargy, neck pain, weakness in the upper limbs, and gait discomfiture. He describes occasional episodes of electrical sensations shooting down his spine on flexing his neck. He has a long history of lower back pain, primary generalized osteoarthritis, and vitiligo. He takes Voltaren regularly. He neither smokes nor drinks alcohol. He is of Philippine origin and he has been in the UK for the 9 years and denies any recent history of foreign travel. He is afebrile. He, his general examination is normal except for vitiligo. Cranial nerves are normal, there are no wasting of the limbs, and there are few fasciculations in the brachioradialis and the biceps on the left hand side. The tone is mildly increased. There is mild weakness of elbow, wrist, and finger flexion, extension, which is more on the left, but the power is normal. There is inversion of the left supinator, the triceps, the jerks are reduced bilaterally. Sensation is also reduced in the C5 and C6 dermatomes. So first you have to note that the patient is a 58-year-old gentleman, and the X-ray findings, if you note the X-ray of the cervical spine, it is mentioned that there are extensive osteophytes which are obvious. So this is a case of a degenerative cervical cord disease or the degenerative cervical spondylosis. It is a normal degenerative age-related process. Gradually, the percentage of population which gets affected rises as they become older. The joints, the discs, the facet joints, and the ligamentous structures can all be affected by the degenerative changes. Uh, you can have myelopathic features as well as radiculopathic features. There is also a possibility that you may get direct neurological damage or you may get ischemic changes as well. Compression, stretching, and angulation can cause radiculopathy, and compression, ischemia, or recurring minor trauma results in myelopathy. Please note that this does not require cervical collars. This generally requires rest, anti-inflammatories, analgesics, and other supportive treatment, and only in the rare cases where you get extensive neurological deficits do you require surgical intervention. What feature would you expect in a 45-year-old lady who has been diagnosed with dystrophia myotonica? Okay, so this is basically an autosomal dominant condition, generally presents in the 20 to 30 years age group, and the features which commonly are included in this symptoms complex is cataracts, ptosis, you may get frontal baldness, gynecomastia, diabetes, and you may have reduced reflexes with myotonia. The general presentation is a weakness with myotonia. A 69-year-old lady with a 4-month history of tremor affecting her right arm presents to the neuro clinic for evaluation. A past medical history is that she suffers from a depressive psychosis for 8 years, for which she has received intermittent chlorpromazine and amitriptyline, but these have been stopped for the last 6 months. She has three sisters who also have tremors. On clinical examination, she has a resting tremor of her right hand. Cogwheel rigidity is present and she has mild generalized bradykinesia. What is the most presumable diagnosis? So this is idiopathic Parkinson's disease. The clue to the diagnosis lies in the question that the signs are unilateral and that is how it usually presents. Remember, Parkinson is an asymmetrical disease to begin with. Later on, with the advancement of the neurodegeneration, it can become bilateral, but at time of presentation, it is mostly unilateral. So, as we all know that it is because of the loss of the dopaminergic neurons of the substantia nigra that this is commonly caused. Uh, a very interesting differential which was given was drug-induced Parkinsonism, but remember, chlorpromazine is linked to it, but she has stopped taking the medicine for the last 6 months, but her tremors are still persisting, so it is unlikely to be related to the drug she is taking. There is also a history of uh, three sisters in the family also having uh, these tremors. We do not know what type of tremors they are, so please do not get distracted by that particular information in the question. These tremors of the sisters should also have been described in detail. A 51-year-old gentleman presents to the clinic with loss of sensation over the lateral 3.5 fingers of his left hand, with tenderness of the left forearm and inability to make a tight fist. He complains of pain in the left arm while twisting door handle anticlockwise. Fallon's test and Tinel's test are negative, otherwise, he is neurologically intact. What is the most likely diagnosis? So, this is a pronator teres syndrome. The clues that are given in the question are that the patient reports a loss of sensation of the lateral 3.5 fingers. So that means the median nerve is affected. And once the patient is trying to make a pronator motion of his left forearm, that is twisting the door handles anticlockwise, the pain is getting exacerbated. If you look at the other options, stroke is incorrect because there is involvement of the peripheral nerves and not the central nerves. Diabetic polyneuropathy is incorrect because it is unilateral. You do not get carpal tunnel syndrome, and you have the Fallon's test and the Tinel's test are negative. And multiple sclerosis again is not the correct answer because you have the involvement of a peripheral nerve and not the central nerves.